17 years of experience in the Department of Critical Care Medicine in 4 major leading tertiary healthcare centers in Hyderabad. He is the founder director of Sparsh Critical Care Group, ISCCM Nation Executive, Joint Organizing Secretary of Critical Care Nation Conference 2020. He is an editor and author of many topics in critical care books and many national and international publications. He is a faculty, examiner, assessor for DNB, ISCCM fellowship courses. Some of his areas of interest are quality initiatives, critical care infectious diseases, sepsis, ARDS, etc. He is going to speak about stroke 2023. Trauma 2023. Music and noise. Over to you, sir.
Thank you, ma'am, for that kind introduction. Good afternoon, friends. It was supposed to be morning. I think we're getting delayed. So my agenda or my topic is trauma updates in 2023, and I happened to call Venkatramana ma'am asking what she wants in this noise or music, what she exactly wants. So these are the recent 23-22 trials which I can look at them, saying they made some noise, they made some music, so we will see what are they. But before that, I'm an intensivist, so I'll stick to my all trauma-related trials and updates and changes concerned to an intensivist. Not about a rib repair, not about a liver laceration repair and all that. That is not going to help me. So if at all I wanted to improve my trauma resuscitation, probably I will define them in this 4 categories. Minimize the iatrogenic injury which we create. And that has been a phenomenon either in the sepsis by early coordinated therapy or in a trauma. I will come to that. So do no harm. That's what is I think the initial medico takes a oath. Second is, how can I take bleeding into control? Do I have any devices to make it better? Promote a homeostasis which is there. Restore the perfusion as early as possible so that you don't lose organ. The surgical part, we will leave it to the surgeons. Damage control resuscitation has been on board for the last 2 decades. We were talking about a permissive hypoperfusion or hypertension, minimizing crystalloid resuscitation, blood products which are given in a way that you don't dilute them, early MS control. This has been there in the 2 decades. What happens in most of the scenarios? You get a trauma patient who is actively bleeding, who is in that lower part saying the patient has normal to low blood pressure. You resuscitate them by 2 large bore cannulas, which is a standard of care which is taught to us by ATLS guidelines, and you give a 2 liters of fluid. The blood pressure for somewhere between 80 to 90 to jump up to 140, and they start bleeding. Okay? And once they start bleeding, they again go back to that low blood pressure and low MAP. You again resuscitate with something else. So this is a vicious cycle which we create. When I was actually looking at all those data, we have been thinking or discussing about this permissive hypertension, judicious use of crystalloids. Is there any data? There are many, but I tried to bring the latest among all, not confined to 2023, that saying कि permissive hypertension versus a conventional resuscitative strategies, and that varies between a systolic blood pressure of 50 to 70 versus probably 65 to 100. That means I target a MAP of 50 or a target of MAP of 65. Again, I will probably try to give a little explanation to this. I have a very badly injured patient. And if this patient had a very bad vascular injuries, tear of a celiac trunk, a aortic tear, they don't reach you, they will die on the spot. And 100% mortality on the spot, they don't reach to any hospital. But those who actually have a little distal vascular injuries or a solid organ injuries, many of them they reach to you, but they reach to you in a hypotensive state. Okay? And most of these injuries, if they are not external, are internal to a probably a mesenteric tear or a liver laceration or a solid organ other injuries or a hemothorax or a vascular tear somewhere in the smaller vessels. if you actually put a cannula and give a large volume of resuscitation, you create three problems there. One, this patient, because of some temporal defect with the hypotension, there is a formed clot which is actually trying to actually compensate and minimize the further bleeding. Now you are, by the 2 liters, you are raising the blood pressure from the mean of 50 or a systolic 70 to 140 and MAP of 100. This high pressure increases again the bleed. One. Second, there is already a liter of blood loss and or 2 liters of blood loss in the system. You have a limited platelets, limited clotting factors, and that gets diluted. The already formed soft clots got dislodged. So these are the effects of dilutional coagulopathy which can lead to further vicious cycle of that. So what are we talking about? If I have a patient who has some internal vascular or some solid organ injury where I can't have a control of the bleeding, I need some surgical procedure or some interventionist is to come and do it, then my target till that time is to keep his organs perfused well. How do I do that? It's not by a macro diagnosis. I am saying it is not by a systolic blood pressure, but I will look at some of the windows of my perfuser. What are they? If I have a patient who is conscious, cohort talking to you. If I have a patient whose capillary refill is good. If I have a patient whose lactates are holding on, probably I will make that acceptable limit and not try to chase to normalize his blood pressure. So this is called permissive resuscitation or permissive damage control resuscitation, and this has to be all of a norm till you get a proper team to actually control the bleed. Okay, so this meta-analysis concludes that permissive hypotension, that is a mean arterial pressure of close to 50 and a systolic pressure of 70 is probably quite enough till you get a proper control over a mean arterial pressure of 65 to 70 with a MAP of with a systolic pressure of 100, which many of our ER physicians or a young enthusiastic intensivist will do. The major problem in this resuscitation is related to the traumatic brain injury, because we all know in traumatic brain injury we don't want our brain to get a secondary hit or a secondary injury. The primary injury at the site, secondary injury because of hypoxia, hypotension and all, we know that. So this is again a tricky situation. We do have patients who will have a bad abdominal injury and also traumatic brain injury. And in those situations, it was told to us that don't target the permissives, you target the normals. But there are new and new studies, animals and humans, which are suggesting you don't need to be the normal way, but you can be somewhere of maybe MAP of 70 will be fine, with probably a systolic of 90 and 100 will be fine. There are trials comparing the MAP of 80, 100 and 120. They found 80 MAP was quite good enough in many of these traumatic brain injury patients. Even right now we don't have a clear answer in them. Excluding them, all other patients, we should actually adopt a permissive hypotension with a probably damage control resuscitation, not a very normal physiological numbers. Crystalloids, as I said, 2 liters, 3 liters of aggressive, enthusiastic volume resuscitation can harm. If I have a patient whose blood pressure is fairly okay, 250 to 500 ml to a liter or a maximum up to 2 liters should be enough. You don't need to actually keep on giving volume. If somebody is not getting his BP up by 2 liters, probably try to allow this permissive hypertension and get the blood products early. Don't dilute them more, and this has been evidence to prove. Then this is the last thing which I will try to talk about is Everett's trial, which is talking about a vasopressor supplements in them. What vasopressors? Is it noradrenaline or a vasopressin? This is one trial which suggests if you control your bleeding, these patients initially from hypovolemic stage, where these all vessels go into a very constrictive stage to support or compensate that hypotension, later can go into a vasopressic state. So using a vasopressin of 4 units bolus and an infusion of 2.4 ml, which we use by 40 units loading in a 50 ml, has shown to be beneficial in decreasing the blood product use. So this is one trial. So vasopressin may come in a big way in both cardiac hypotensions and also this hypovolemic hypertension. to summarize, to minimize the iatrogenic injury, to accept a permissive hypersensitive strategies, except probably in a traumatic brain injury, crystalloids should be used judiciously to target your probably windows of perfusion, not as a numbers, and vasopressors need can be titrated between noradrenaline as vasopressin. Controlling bleeding. See, as I told, we will not go into the surgical component, but this is the new device which has been into availability called Robia. So, Riboa is been something which looks like this, which has a balloon to occlude. If a patient has a very bad abdominal trauma with vascular injuries, we have seen the young people like 20 years, 18 years coming to ER, they will be talking, but you will be seeing the abdomen has been just bulging like that, you know there is some aortic or a celiac artery rupture. So these are the patients where this has been tried through a femoral artery to reach this to one of probably into the abdominal aorta above those injuries and just inflate the balloon. And this Riboa has been tried, and this is the trial in the last year, which is suggesting that after this use of the Riboa, there is no difference in the mortality. In fact, there was some more, maybe 3 months mortality in the Riboa group. So this trial has shown that Riboa is not useful. This is a tool which we all thought about those who have a torsa injuries with very bad vascular injuries. This device can give us an answer, but this has not shown to be. So secondary outcomes also in 3 hours mortality, 6 hours mortality, in 24 hours mortality, and over the 2-3 months also it could not show. The reason probably is delay in damage control surgery or delay in actually a definite surgery, because you have taken into the control of the bleed. So maybe that is one reason. And the selection of patient. Is those patients who are too sick were selected, or all those patients were selected which can have been managed conservatively? So these are the areas which are debated, but this is a device where I was searching about if a vascular injury is there, what can I do? My surgeon used to open the thorax, clamp the aorta. So that was a technically not easy process for any intensivist. So this is the device which we can use. At this point of time, this trial is negative, so we don't have a concern. Then I wanted to just bring you this proper trial. We all were talking about the resuscitation of a massive transfusion protocol. If somebody is bleeding, needing a 3 units in a half an hour time, you don't need to whole blood to be replaced. That we call as a massive transfusion requirement. You need a massive transfusion team, and 1:1:1 was the protocol which we generally know. This trial compared with that to 1:1:2. That is 2 packed cells is to 1 plasma is to 1 platelet. Is there any difference between these two? So they didn't find any difference in the primary outcome in a statistical way, but they found that the patient who received 2 packed cells is to 1 plasma is to 1 RDP had a more extenuation induced deaths. So what I take from India where many of the centers we may not have adequate plasma and platelets. So we do use RDPs more packed cells more than RDPs and FFPs. So this can be one way. If I don't have, I can use probably 2:1:1, even though I know it can still be a risky. So this teaches me that if I don't have 1:1:1, 2:1:1 is also fairly okay, except in some situations. Cryostat 2 trial. This again, we all know in many PPH cases, many situations where fibrinogen replacement has been considered as one component when massive bleeding is compared or massive transfusion is needed. Keeping a fibrinogen level more than 100 in a normal individual, in pregnant PPH we target somewhere between 270 to 300. And this trial compared giving a 3 units of cryoprecipitate, which is close to 6 grams, and saw whether it has helped in any outcome. And this could not actually see any difference in making these patients better than the regular 1:1. Adding cryos has not been helpful in trial. Refill trial, this is again a pre-hospital blood transfusion. We are all talking about replace the products lost. Blood lost, replace blood. But where is it available? It is in the blood bank. And many of our hospitals may not be geared up for O negative pool of blood. So this hospital, this product refill is a lyophilized plasma along with the packed cells which are available in the ambulance. They give it in the pre-hospital setting, but this didn't show any difference than standard of care. Coming to the hemostasis which we were talking about, the tranexamic acid, we have seen the whole trials of CRASH 2 and 3, and this is the patch trial which again done by Angie group, both New Zealand and Australians, comparing the tranexamic acid in trauma, giving a gram initially and another gram in next 8 hours of infusion. They could not found any difference in these patients' blood product requirement and outcome. And maybe the lower part is there is no even adverse effect of tranexamic acid. CRASH 2, CRASH 3 trials had a mortality benefit, whereas the patch trial suggests there is no mortality benefit. So, in summary, I had a few trials which came in the last 2 years, and that is confined to intensivists. Damage control resuscitation for uncontrolled bleeding should be way forward. Permissive hypotension, looking at windows of perfusion should be considered. Don't use crystalloids by just putting 2 IV cannulas without any target of your MAP and systolic blood pressure. Maybe maximum target crystalloid should not exceed 2 liters. Vasopressors, we are having more and more data on vasopressin role in trauma. Probably in massive transfusion protocol, we probably are talking about 1:1:1 as an ideal at this point of time, even after the appropriate trial. But if I have a resource limitation, 2:1:1 has shown to be equal effective, except exsanguination was little more in them. IV tranexamic acid in a major trauma at this point of time, in spite of that being negative, I will continue to use on the basis of CRASH 1 and 2 trial. The reason for that is I did not find any increase in adverse effect in any of it, even though it doesn't show any positive benefit. I will try to mention 2 more things which I didn't cover is whole blood. See, like in ICU, when we were medical students, the whole blood was a standard of care for any patient who actually had a massive blood loss. Okay? And fresh whole blood was the ideal blood for a cardiac surgery. That's what was taught to us. Later on, when we were into end of our graduation and post-graduation, it was told, no whole blood, it is all components. Somebody talking about whole blood is not aware of a newer updates and guidelines and is going away. Then it was told to us that fresh whole blood may not have any advantages over the others, the products are the better, so there is no need to give fresh whole blood. Right now, we again take a complete circle and coming back with a lot of trials, including in the warfoot areas, where in trauma and military army injuries, where the fresh whole blood has been replaced and shown to be equal efficacious like 1:1:1. So we are probably taking a complete whole circle and coming back to that as one point. So that there are a lot of studies on whole blood. So that concept which we all were taught 20 years back may not be wrong. The whole component processing, using it for more patients may still valid for those who need components, but whole blood may have a role to play. Second, the vascoelastic test like TEC and the Rotem. In a trauma, believe me, I had a situation where a patient is actively bleeding. I don't know whether I need platelets, I need FFPs, I need cryos, or I need an antifibrinolytic agent. A quick TEG in these DIC patients or those patients who are needing a massive transfusion can give me an answer, you need tranexamic acid. This happened to me. I gave 2 grams of tranexamic acid, gram loading, gram over 8 hours, patient's bleeding stopped. That is an antifibrinolytic agent which was deficit in, as per the TEG report. So that will add to your probably interpretation of this. That is also coming big way in trauma. So I think this is all practice changing patterns which I am seeing in the last couple of years or so. Thank you.
Thank you, sir.